Great, it's nice to see everyone here today, and it's nice to have a face-to-face talk, and I'm pleased to give a perspective from primary care on the importance of early diagnosis of heart failure. And Gavin's story, I think, is really important about how he got the right care and went down the right pathway. And he's demonstrated excellently how continuity of care matters. And we know from all the primary care data that when you get continuity of care, your outcome's better, your prognosis is better, you have fewer referrals, and you live longer at home. So it was really great to hear that. If we contrast that to Sarah's story, she had a delayed diagnosis. It took a while for her to find the right diagnosis and go down the right pathway. And I'm hopefully going to show you some of the problems we have in primary care, particularly since COVID, on how we access and see patients. So what's changed is in the past 2 years, our doors got locked and everything got moved to phone calls, e-consults, and video consultations. So I work in a 12,000 patient list surgery. We have 10 doctors, 3 practice nurses, 2 HCAs, an AMP. We're well staffed, and our typical Monday morning surgery will be heaving. So that's what it looks like now. So when you look at the surgery on a Monday morning, the doors are closed, the room is empty, yet we're busier than we've ever been. So in an afternoon surgery, it looks like that. We might bring a patient in that needs to be seen. So things are different. We're working in a completely different way, and most of it is telephone triage. So the challenges for primary care, particularly around early diagnosis, and when we see this great new pathway, is that the pathway requires patients to recognize there's a problem, then they've got to get an appointment. It requires GPs to recognize the symptoms and then consider the diagnosis of heart failure. Symptoms such as breathlessness have many causes. Most of the patients we see in primary care with breathlessness will not have heart failure, so we do need to consider it. The average age at diagnosis is 76. At 76, we've already heard these patients will have other comorbidities. This will throw us off the scent. And when you get a patient like Sarah who's young, it isn't at our forefront when we're considering that particular diagnosis. So I'd like to share with you a telephone consultation I had with a patient. This was just a few weeks ago, and his story and how it unfolded and how the challenges came up in primary care. So I got a call on a busy on-call day saying the carers requested a call for Brian. He's 78, both ankles are swollen, the right was worse than the left, the skin's red, he might need antibiotics. So I was thinking, great, that sounds straightforward, some antibiotics, I can get this one closed off fairly quickly. And that was what my day was looking like. So in primary care, we have the pink slots in my surgery are the pre-booked and with some capacity on the day. So we have 12 slots. The 3 slots are for people that we need to see face-to-face. We don't normally get reds. Reds are when we've exceeded capacity, we need to start seeing more people. And so we were up to 10, I was up to 10 extra patients that day. So that's 25 contacts in the morning. That was pretty similar in the afternoon. So when I got a call saying that Brian had a red leg, a bit swollen, might need antibiotics, I was thinking, how quickly can I write out a prescription for flucloxacillin and get him sorted out? So I thought I'd better just take a look at his records. So Brian was 78. He's had an MI 20 years ago. He had a reasonable quality of life up until 2 years ago, but had reported slowing down. And this was at a nurse blood pressure check a few months ago. His past medical history was one of ischemic heart disease, hypertension. He'd had a past TIA. He had prostate cancer, which just been managed conservatively. And he was on the usual meds, perindopril, amlodipine, aspirin, statin, PPI, and something for his prostate. So decided I'd better give this guy a ring. So when I spoke to Brian, he told me he had a fall 4 weeks ago. He was admitted to Southport Hospital. He had urinary sepsis and an AKI. His perindopril was stopped during the admission. He was discharged home with a re-enablement care package after 4 days in hospital. He'd been sleeping in the armchair. Mobility was not so good. His legs felt heavy, sore, and he was more comfortable sitting in the chair than lying down. So before we carry on with Brian's story, I thought we'd just look at the challenges for primary care and why are we not picking up heart failure as quickly or as readily. So there's a really nice article, an open article in the BJJP earlier this year, looking at how we can get better with a faster, earlier diagnosis. And when they analysed primary care data, it showed there's often significant delay between the initial presentation and referral to specialist services, with missed opportunities for early diagnosis and treatment. older patients often attribute their symptoms to be a normal part of aging or to a pre-existing long-term condition. This is really important to me. Family members were often the first to notice that something was wrong and were instrumental in facilitating that first contact with the healthcare service. So for me, if a family member rings up and says, I'm worried about somebody, I think that they're not right, it does ring my alarm bells now. Currently, 4 in 5 people with heart failure are hospitalised around the time of diagnosis. So there's lots of missed opportunities. You've seen what the surgery's like and how we're operating. It is a challenge for primary care. So, decided to go and see Brian. No choice, he clearly needs to be seen face to face. As I arrived, his daughter had called round, and first thing I was greeted with, did the carer mention how tired he was? He's just got no energy. So when we looked at his legs, they were like that. So we have an alive core, he was in sinus rhythm, he was a little bit tachycardic at 94. He had basal creps, his blood pressure's up a little bit, heart sounds were normal. So how useful are these signs and symptoms for diagnosing heart failure? So, nice article in the BMJ back in 2000, looking at sensitivity and specificity for diagnosing heart failure. So we can see the predictive value isn't always great, but when we take them together, we can start picking out patients who might have heart failure. So orthopnea is a good screening question. When we examine our patients, basal creps, tachycardic, ankle edema, these start making us think about heart failure. In primary care, when we're on the telephone, we don't get that. We're missing that, and so we need to see the right patients. We've all heard of the FAST campaign, face, arm, speech, time, when we're doing stroke assessments. We've now got the BEAT-HF campaign. So, is the patient breathless? Are they exhausted? Do they have ankle swelling? If so, it's time for a simple blood test, the end-terminal pro-BNP. So if we look at the pathway has a really good slide. We've seen this already from Dr. Din about case finding and early diagnosis. The problem we have in primary care with case finding is that we're being very reactive. We're trying to deal with on-the-day demand. We don't have time to be proactive, to look at our registry database to find out who are we missing, who don't we know about, which patients have heart failure that are just managing, struggling at home. And so we've engaged with primary care heart failure services to be a bit more proactive at my practice, and we're hoping to roll that out across our local network, and I'll explain a bit more in a few more slides. But I like this slide for early diagnosis, and in particular this area. So in primary care, when we need to consider heart failure, the following comorbidities and symptoms should just alert us to that. And we've heard this comment, particularly from Sarah, the recurrent chest infection not getting better. So if we keep doing the same thing, we're going to get the same outcome. And if the patient isn't getting better, we need to take a step back thinking, have we got the right diagnosis? Which pathway are we going down? So the outcome for Brian was really quite straightforward to make him feel better. So we restarted his prindopril, we stopped his amlodipine, we put him on some furosemide, we give him a low dose of beta blocker. His daughter was going to bring him in for an ECG at the surgery in a week, along with a blood test. Arranged these blood tests, and he's been referred for an echocardiogram. But most importantly, he didn't need antibiotics. And his BNP has come back at 2,000. Within a few days of diuretics, he felt better. He was mobilizing better. He just generally felt better. So there's some simple interventions from primary care that only happened because we saw him. So the breathless pathway, you've already seen the slide again. I find this really helpful when we have a breathless patient to consider what tests we do. And it really is about the BEAT-HF campaign. Are they breathless? Are they exhausted? Do they have ankle swelling? Let's think about the BNP and an ECG, but we should consider other diagnostic tests. And for primary care, we need to be confident that if the BNP is normal and the ECG is normal, that they don't have heart failure. We can exclude it, and we then go down another pathway. So I mentioned that we've been proactive in looking for our heart failure patients. So we've worked with primary care heart failure services, which is a 5-stepped approach, which involves interrogation of our primary care database, looking for patients that have heart failure, staging the severity of heart failure, looking at drug therapy, looking for opportunities to change and optimize drug therapy, and then identify patients who might be suitable for devices and more specialist care. And so phase 1 is a system interrogation. This has no work for primary care, by the way. All we need to do is have data sharing agreements. The team will come in, look at your data, identify this list. The advantage to primary care is we improve our QOF register, we increase our prevalence, patients go in the right pathway with the right treatments, and we have increased practice income. So the second phase is the medical records review. And so an extensive audit's done. There's two audits done looking for patients with LVSD, prevalence against NICE guidance. Audit 2 is assessing patients who have indicative terms in their medical records that might suggest a diagnosis of heart failure. The patients are then invited for a review, and this is with a consultant cardiologist, and they'll have a virtual review to look at what the auditors have identified to see who would then be suitable for a face-to-face or a telephone review. They're then invited in to have that next review. Phase 4 is the actual consultant review, so that you'll get a consultant that will either come out to the practice, so the patient is treated at their local practice. The advantage for the practice is you've got a consultant on site. There's one-to-one if you want to have a chat and discussion about any cases, some education. The patients will have an ECG on arrival. We have our own ECG machine, so the ECG is uploaded straight into the EMIS records. It's there for reference. Patients are then optimized for treatment. Anyone identified for high risk or further investigation are then referred back to the host site, which in our case was LHCH. And that was no work for primary care. We have a referral template, and it was just devices clinic, and it will be for an echo, MDT discussion about device, and it would go back to heart and chest. Matt would review that and create a pathway for that patient in tertiary care. The final phase was about follow-up, and patients are audited at 3, 6, 9, and 12 months. And the aim is to make sure, have we done what we set out to do? Are the patients on the right pathway? Has everything been implemented that was set out to be done? This has been so successful. The plan that we want to do now is we put in a bid to do this across Southport and Formby, which serves 130,000 patients. And we want to replicate that to support primary care to be proactive without increasing the workload for primary care. So we managed to recruit another couple of practices in Southport and Formby. So the data we've got so far is that we've reviewed just under 40,000 patients. That's 525 patients on the heart failure register. 870 medical records were reviewed. 279 were identified with LVSD but weren't coded. 37 patients were identified with severe LVSD and had a clinical review at the practice by a consultant cardiologist. So at my own practice, this is the data for Ainsdale Medical Centre. So we identified 6 patients suitable for complex devices. One's had the CRT-P implanted, 2 are on the waiting list, 3 who were eligible chose not to have it done, and 14 patients required medical optimization, and that would be transition to Entresto, SGLT2 inhibitor initiated, MRR initiated, or up titration. So we want to just demonstrate the case that had his device implanted. So he was an 85-year-old chap, 79 kilograms, past history of revascularization and valve replacement in 2018. He was diagnosed with his bladder cancer a year later. He had an echo at that time showing severe LVSD, and he wasn't on our radar. History of hypertension, CKD. He was on fairly standard meds. He didn't tolerate an ACE inhibitor, and so when that was discontinued, nothing replaced it. He had a consultant review in May. He was classified. This is a summary of the consultant record. He was referred up to LHCH, had a repeat echo, and he was discussed at the MDT at LHCH, put in the waiting list, and had his CRT implanted in September 21. I've reviewed him since. He's feeling a lot better. He's a big responder to his device. He's V-pacing at 95%. We've increased his beta blocker, and hopefully that'll be even better. And he feels better. So in summary, we need to recognize the problem, and we need to remember the Beat HF campaign. I think it's important to listen to family members and any concerns they have. We need to think about patients not getting better after antibiotics. And I think we have to see these patients. Anyone presenting with breathlessness on a phone call needs to be seen. Otherwise, we'll give them antibiotics. And we should consider an ECG, simple blood test, and consider which pathway they go down. And I would recommend, if you have the opportunity, to engage with services to help for case finding and optimization. It's a great quality improvement project. Looks great if you get a CQC inspection. It's great for appraisal, but importantly, it feels good to do something useful to your patients. Thank you.